Hello guys, welcome to Medley and Life. In this video, I am going to discuss about the hypoglycemia. It is one of the important repeated short notes in pediatrics. And I am going to discuss about the management and clinical features of the hypoglycemia. What is hypoglycemia? It is the less than 45 milligram per deciliter blood sugar level is hypoglycemia. And we can screen the hypoglycemia in high risk people. Okay, next step I'm going to show who are all the high risk, and if the baby born with appropriate for gestational age, we no need to for screening, and we just give adequate breastfeeding is enough. Okay, the high risk people are inadequate substrate means small for gestational age, that means weight for age gestation is less than third percentile, and gestation below the 35 weeks, and birth weight is less than 2 kilogram. These are all inadequate substrate. And relative hyperinsulinemia means infant of diabetic mother. The mother is a diabetic, and the infant also maybe have a hyperinsulinemia. It leads to hypocalcemia and hypoglycemia and hyperbilirubinemia. And large for dead baby means weight for gestation is more than 97th percentile, and also RH incompatibility female have also leads to hypoglycemia, and intrauterine growth retardation also have a hypoglycemia, and sickness, hypothermia, sepsis, and hypoglycemia and hypothermia and sepsis. These are all triad, and asphyxia. These three category people we have to screen. These three category of the people have a high risk of developing hypoglycemia. That means small for gestational age, less than 35 weeks of gestation, and weight for birth weight is less than 2 kg, and intrauterine growth, and infant of diabetic mother, and hypothermia and sepsis asphyxia. And when are all we have to screen? After the birth, from the birth, after the 2 hour and 6 hour, and after 12 and 24 up to 72 hours, we have to check the blood glucose level with uh, reagent strips. Starts from 2 hours to 72 hours, 2, 6, 12, 24, and 48 and 72 hours. Okay, and clinical features. Hypoglycemic children presented with lethargy, pallor, difficulty in feeding, eye rolling. It's related to seizures. Hypoglycemia also leads to seizures development, and hypothermia, and stupor, tremor, and cyanosis, convulsions, apneic spills. That means the baby have high breath, okay, tachypnea, and weak high pitched cry. These are all the clinical features. And cardiac arrest also present, but it is rare. The main clinical feature is starts from pallor, lethargy, and related to these seizures, convulsions, and tremor, and tachypnea. These are all the clinical features. How we are going to manage the hypoglycemic uh, children? First, it is asymptomatic and symptomatic. If it is asymptomatic with some other clinical features, that means we have to do first blood sugar level. If it is less than 20 milligram per deciliter, we have to start trial of oral feeds. Trial of oral feeds means we can give breastfeeding or some other uh, milks also. That means trial of feeds means continue to feed, and check the blood sugar level after 30 to 45 minutes. If it is more than 40 milligram per deciliter, we have to continue the feed. First, if it is asymptomatic more than 20 but less than 40 means we have to start trial of oral feed. And if it is more than, then check 30 to 40 minutes. If it is more than 40, we have to tell the mother to continue to feed. Or if it is no improvement, it is again less than 45 milligram per deciliter, means we have to start IV glucose infusion. Okay, this is the asymptomatic management of the hypoglycemia. And coming to symptomatic management of hypoglycemia. In symptomatic management of hypoglycemia, we have to give bolus of 2 ml of per kg of 10% dextrose first. Okay, then immediately we have to give glucose infusion 6 milligram per kg per minute. And after 30 to 40 minutes, and check for blood sugar level. If it is normal, we can continue to give 6 milligram per kg per minute up to 6 hours. And there is no improvement, means we have to repeat the um, hypoglycemia. We have to give extra 2 milligram per kg per minute every 6 hours. Maximum we can give 12 milligram per kg per minute. And again check for blood sugar level. If it is more than 50 milligram per kg per deciliter in 2 to 3 consecutive values, we have to taper the blood sugar level from 2 milligram per kg per minute every 6 hours. And along with, we have to tell the mother to continue to oral feed. Start the oral feed. That is the management of symptomatic. If it is asymptomatic, we start trial of oral feed. If it is doesn't work, we give IV glucose infusion. If it is symptomatic, we start from 2 ml per kg of 10% dextrose and immediately start glucose infusion 6 milligram per kg per minute. And if it is not uh, useful, we have to give again 2 milligram per kg per minute. We can extend up to the 12 milligram. Okay, if it is the further two consecutive values are more than 50 milligram per kg per deciliter, we have to taper the uh, glucose infusion 2 milligram per kg per minute every 6 hours. And we have to educate the mother, and we have to guide the mother to breastfeed or give oral feeds. Start the oral feeds. That's it. Thanks for watching. Subscribe to my channel, share to your friends.